is quite irrelevant actually, about which people don't talk, but they don't use it globally. And that's the way we started our work. And we started around a year back, about which people don't know. We spoke about air quality, spoke about OPU needles, ET catheters, musculature. And look at the tube. And look at the ischemic junction. You'll find tube is like this. AP dimensions. Now there is something called sensitivity and specificity. These are numbers which may vary. Cavity space, maximum 4 ml. A majority have less than 2 ml. And we are pushing in 8 ml, is turning into like this. And then it is going, and there is some spill, which is not a very good spill, but spill is here. Do you find these mucosal folds here? Yes or no? Very respectable way. Now, in case you put a lot of dye quickly, then this fold won't be seen. Then it will become something like this. Because I feel that she may be having some problem, but presently she is fine. Look at this particular tube, uterus now. But that's the way the whole physiology is simple. Simple mechanism of body's healing and response. So tube is
transmission?
Yes.
It may be thinner.
Yes, I'll just come to move ahead. Okay. Otherwise, I'll come in the end. Otherwise, I'll.
Okay, sir.
Those are beautiful films I've showed to you.
Okay, sir.
I told you we won't go into theory.
Okay.
I'll show you things. But it's in hydrosalpinx, and there is a block.
Yeah.
Good.
Femoral block.
Femoral block.
Right side patent. But
Sir, what about the right side?
it's beaded.
Look at the
The
right side.
right side looks
These are beads, and I think spillage is there. But
This is
still
the-
there are beads.
This may be a bead, but you find the rugosities are still preserved here.
Yes. Sir.
Good. Good enough. Good enough. I just want to make you think. See, I can't become a professor. You can't become a professor in 40 minutes. It's a new topic which you are picking up. I just want to keep open the thoughts in your mind. Comment upon this tube quickly. I only give you now.
Logged tube, hydrosalpinx.
Bilateral
Rigid.
Hydrosalpinx on both
Rigid with
sides.
hydrosalpinx, sir.
with
8-pipe tube, sir.
gel on left and right side is dilated.
Rigid tube with hydrosalpinx and femoral block.
Good. Good, good, good. This is again a hydrosalpinx. Now, is this a bead? Is this a bead? 1 and I'll say 1, 2, and I'll say 3 and 4. Which are beads?
3 and 4.
Right side is buckle.
4.
The 4 is bead.
1 and 2 are
3 and 4.
And
3 and 4.
4 is bead.
I'm gonna give you 5 hearts. 5 hearts. Fantastic. Fantastic. कुछ और कोई मेरा दोस्त कुछ और बताएगा इसके बारे में? कुछ दिख रहा है इसके अंदर आपको?
Rigid tube.
कुछ और दिख रहा है? Something very exciting I can see here.
So there's intravasation of dye also.
Yes, maybe. Something more beautiful here I see.
Cervix. Stenosis.
No.
Cervix.
No.
Cervix.
Endometrium देखिए. Look at endometrium. Endometrium. Next here. This is called endometrial hyperplasia. Typical of tuberculosis. You'll find endometrium becomes, in case it is, TB will always cause inflammation. Endometrium becomes hyperplastic.
Later on, endometrium becomes fibrosed and there is anemia.
Exactly. So initially it is hyperplasia.
Yeah, due to inflammation, from chronic inflammation.
I just want to keep things open. Fine. I just want to keep your mind open. That's all. I've told you, just early TB is always synechia. Early TB is hyperplasia, and then it has become this bead. Look at this now. Tell me what it is. Any of my friends?
Can you repeat ultrasonography?
I always say that we'll have a chocolate round, but somehow we are not able to do it. I don't know. Probably our team is not very big till now. But I think this chocolate round diagnosis.
RPH uterus.
Arcuate uterus, yes, maybe arcuate, maybe
Why cannot?
bicornuate. I won't
Sir,
go to this.
endosalpinx is erodiate.
Irregular
Endosalpinx is
uterine
erodiate.
outline, sir.
So now come to,
Dating.
so no chocolate for anyone. You have to give me chocolate for teaching now. You have to give me chocolates now. Now this is the tube.
Dating on right side.
This is a tube. Dye goes from here, right or wrong? Right or wrong?
Yes, sir.
Yes.
Yes.
Then when the TB bacteria starts eating here, bacteria is eating here, what will happen?
Bleeding.
Erode the endosalpinx and cause circulations.
Pouching.
Couching or circulations.
Dye will look like this.
Yes, sir.
What do we call it?
Couchage or circulations.
SIN. SIN.
Salpingitis stomach nodules.
Yes. So beautiful.
Okay.
So beautiful. So beautiful. SIN. It's called SIN. Changa? S is SIN. And this is affecting the isthmus. But the ampullary folds are intact. Uterus has got filling defects. This is typical of COX. Good. What is this? SIN.
SIN.
SIN with hydrosalpinx. Tubes are bad tubes, all beading here and there. Beads are seen.
So uterus, where is
So where is the uterus?
Uterus is somewhere. Uterus is this uterus. This is the second uterus is going. The tubes is going. This is a tube, and this is the uterus. This is cervix. Shrunken uterus.
Lateral view?
Cicatrized uterus.
Sir, is it lateral view?
Yes.
Sir, is it lateral view?
This is a view. No, not the lateral. Yeah, maybe lateral view. Correct. This is the AP view we are getting, in which, in case you turn the uterus, probably it will become like this in some view. But such uteruses are known to be totally cicatrized. Asherman fibrotic uterus. The uterus may be like this, but uterus may be like this, but the cavity is gone. Cavity is small. This is what I want to tell you. The uterus may be big uterus, but cavities become very thin due to additions. Rare film, today's world.
It could be rotated uterus.
Maybe.
We are seeing the lateral side.
I agree. I agree. But such uteruses are normally thin uteruses. The reason being, this uterus, when you look from here like this, it's a healthy uterus. So dye we see here, no? But when the uterus cavity goes for a 6, the cavities become like this now. Uterus is big, but cavities become small. So think what I'm trying to tell you. Just think about it. Look at this. Again in hydrosalpinx. Again in hydrosalpinx. These films are still seen once in a while. Again in hydrosalpinx. Now here you'll find that there are filling defects occurring here. There are filling defects. Filling defects are occurring here. These are the filling defects in the uterus. So keep it in mind that keep a watch on these things. I'll skip this. This is an ovary with calcification. I'll skip this. I'll skip this also. Go to a polyp now. To 9:32. 15 minutes to finish. Look at the cervical cavity polyp. A polyp is a foreign body. In case this is a cavity, you'll find polyps coming. So polyps come like this in the cavity. So polyps look like black shadows. On ultrasound, they will look white, and on HSG, they will look black because they are filling defects. So let's see. Nice arbor vitae. Polyp, filling defect, polyp, small filling defects are seen. These can also be seen in PCOS when they have endometrial hyperplasia. These are filling defects.
So this could be a little bit of Asherman also, no?
Which one?
This first picture, sir.
Maybe, but
Where
this when they corroborated this with an ultrasound and hysteroscopy, they found a polyp.
Okay, sir.
See, many of the pictures have been corroborated, no? When they have found it's a polyp.
All right, sir.
So what the pictures I'm showing to you today, they are confirmed pictures. I'm not talking. See, interpretations मैं mold नहीं कर रहा हूँ. I've taken the pictures from somewhere. Some are my pictures. They're all confirmed pictures. It's not that I've just leave it blank, open in any direction. It's not happening like that. That you must be assured. Look at this. Polyps.
Sir, filling defects, yeah, polyps.
Multiple polyps.
In the fundal area also.
Yeah.
Sir, tubes.
Tubal
Tubes are
polyp.
blocked.
Tubal polyp.
Oh,
So polyps can be in the tube also. We have a polyp here also. See, polyp here. The tubal polyps are also known, though I have never seen. Cavity additions. Addition means some sort of septas they occur in the cavity. Additions they occur. This is an end-to-end addition. Filling defect. Regular filling defect. Polyp is a floating sort of a filling defect like this. But additions, when you get very demarcated end-to-end filling defects. Filling defects again, they're all confirmed. You have a filling defect here, filling defect here, you have a filling defect here. These are all the cases of
Maybe
intrauterine
tuberculosis.
septa or additions, whatever they are. Infective septas. Here, this again a filling defect. They're all confirmed pictures. None of the pictures I'm showing to you today are the pictures which I'm doing it on my own. There is no misinterpretation or misrepresentation of the facts. Look at this. Now, this is a very beautiful picture. You will find that the whole uterus is gone here. Nothing is seen.
No uterus, yeah.
Multiple beads you can see. Big beads you can see here. There are multiple beads and there is some interposition. The uterus is gone. It's all cavity is gone and they're all filling defects everywhere. This is an Asherman syndrome with gross endosalpingitis, tuberculosis. Can we diagnose adenomyosis on ultrasound? Yes.
Yes, sir.
Yes. This is adenomyosis. When we have outpouching occurring from the endometrium to the myometrium, these outpouchings, like in our classes, we talk about a lot about adenomyosis. It's a favorite subject when we have an ultrasound around for you guys. These are all the adenomyosis. Differentiate between adenomyosis and endometrial carcinoma. That I'm sure we know how to diagnose, but they both can look same. Adenomyosis, outpouchings. Outpouchings are called, these are called adenomyosis. Again, outpouching in the uterine cavity. This is a uterine cavity, no? This is a muscle. This is a cavity. This is a uterus. So when the dye start moving in, it is called adenomyosis. This I have taken from the internet. I don't myself understand DES, but T-shaped uterus. Old picture, I just showing you for some just understanding. Endometrial carcinoma. Look at this now. So be careful that early CA can look like this. So just want to give you some inputs. That's all. Not that we are diagnosing carcinomas by this. This is an endometrial carcinoma. Okay. Look at everywhere the things are going bad. Myomas can be intramural or submucous. Submucous is never a problem. They will come as a filling defect somewhere here. This is now intramural, which is pressing the cavity. This This is called an intramural myoma. Here again, look at the intramural myoma, which is pressing the uterus completely in one corner. This is the myoma. Pushing it further. Okay. Now look at something nice, different. Look at this myoma. One myoma here, one myoma here. They're filling defects. They look like this actually. So myoma is pressing it. Intravasation, our favorite. We keep showing off these things to people, but it may be due to the wrong technique. Maybe it's the wrong technique we are using. All intravasitions, pressure is high, or there is some injury to the endometrium, or tuberculosis, or some infection, multiple reasons, but this is not the condition in which we always say it is due to the pathology. It can be our creation also. But whenever it is there due to with other associated factors, keep TB in your mind. You can see the pelvic vessels getting involved. So I think that's it. This is about intravasation. Uterine anomalies, quickly, 2 minutes, we can get. What can be this? Anyone?
Unicornate uterus.
Unicornate.
What can be this?
Arcuate uterus.
It can be
Arcuate.
Arcuate or T-shaped.
Yes.
T-shaped.
Septate uterus.
Septate.
Septate uterus. Well, it is in a very acute angle. What is that?
Unicolous.
Uterus diadelphus or back
Diadelphus. Uterus diadelphus.
What is this?
Complete
Same thing, diadelphus.
Septum.
What is this?
Complete septum.
This is
Diadelphus.
biconate.
This is
This is diadelphus.
Diadelphus with bicolor.
Bicolous.
Correct. It's fine. This is
Diadelphus with
no.
This
Biconate.
biconate uterus
Biconate.
with
Biconate.
unicollis. Unicollis biconate uterus.
Good. Angle is more than 105 degrees. So this is the type of C you get in the diadelphus. Okay. This is a unicornate uterus. So we have to actually keep it in mind how much pressure we are applying, how much time we do an HSG for, what all you want to diagnose. Premature reflex has to be seen. So I'll leave some thoughts for you here now and learn from you. What is this?
Adenomas.
Excess amount of, I think,
Extravasation
dye has been pushed in.
adenomyosis.
C endometer. It is C endometer.
Okay.
You have to keep your mind. I'm keeping your mind open. That's it. What is this?
Myoma.
Myoma.
It's a polyp. It's a polyp. Big polyp. What is this? What is this? What are these?
Ovary lined by the dye.
These are the lymph nodes.
Okay.
This is the ovary. This is the lymph nodes are also seen sometimes. What is this?
Lymph node and
Bleeding.
What are these things? This is called no. System SIN will occur here, madam.
Yes.
isthmus.
This is rosette shaped collection of
Fimbria.
the
Rosette fimbria.
rosette. What is this now?
Which
You
one,
all-
sir?
Thick tube.
Thick tube. Thick lead pipe tube.
Club shaped tube. And this is a roseate pattern. I'll send you all the patterns sometime. What is this now? Who's gonna get a chocolate here now? Last time you all lost a chocolate on this. What?
Yes, I understand.
Good. Lovely. Fantastic. What are these things?
Beads.
Left side is the bead. Right.
Beads and fimbrial blockage. Loss
Good.
of embryo.
No, they are.
Perfect. So beading is what we'll tell. So remember the tubes can be thicker also. You were saying tubes can't be thin. They can be thicker. See this, thick fleshy tubes is tuberculosis.
Hydrosalping.
This is called cobblestone. This is called cobblestone pattern of terminal dilatation. Here are some names have been given. This is a club-shaped.
Sir, cogwheel. Can you do cogwheel?
No, they're called cobblestone.
Okay.
I'll send you the things. मैं भेजूंगा आपको मैं थोड़ी देर में तब समझ जाएंगे पढ़ेंगे तो।
SIN. This is SIN with arcuate uterus.
Arcuate uterus, arcuate or maybe bicarbonate.
Bicarbonate.
I don't know. Angle is obtuse. I have not measured that. I don't know. But it is SIN. Thank you. Lovely being with you guys. And I couldn't thank all of you personally, but we had nearly 60 candidates, friends who had come down to Delhi to learn in the past 10 days. Thank you so much for being with us. And I invite you all for a 15 hormonal evaluation.
Thank you.
Good, sir.
Hello.
Hello. Thank you, sir. And thank you,
you, sir.
everyone.
Thank you so much.
So we have now Dr. Famida with us. Am I audible, sir?
Yeah.
Hello. Sir,
We have the editor of today's resonance today.
Where is she? Where is she gone?
Ma'am, please join us. She was having some emergency in the morning, so she couldn't join us in the morning. So
Great.
where are you, ma'am?
meanwhile, sir, I'll ask you one question, sir.
Hanji. Hi, Baman. How are you?
Hi, good morning, sir. I'm fine. How are you, sir?
Very
Sir,
fine.
we are doing HSGs in follicular phase.
Hmm.
After that, we are not giving any contraception like barrier contraception or other things. So, in that phase, if patient conceived, does the X-ray effects comes or any hazard of that radiation?
No, see the actual radiation. That's the reason we tell people to use some contraception.
Yeah, because usually we won't tell, no, sir.
No, we tell, no? We have to tell.
Yeah.
HSG is a planned thing. HSG can't be done. Okay, today you come and do an HSG. As I told you, I plan HSG 1 month prior.
Okay.
So HSG has to be combined with an ultrasound.
Yeah.
See, plain simple HSG won't give me anything. We need to carry out a 3D or a 2D for that patient in the morning.
Yeah.
How we do it that we call them next month.
Okay. So barrier methods you advise.
Yeah, always. You tell them, no, I don't advise them anything. That will tell them not to become pregnant, whatever they want to use,
Okay.
but not OC pills.
Yeah.
Because they want to look at their endometrium also.
Okay.
So in the morning, 9 o'clock they come, get the scan done, and then they go for HSG the same day. And the whole evaluation gets over within 1 hour. This is the way I do it.
Yeah. Thank you, sir. Very
But I
nice.
keep it very simple, very simple. So there's no conflict there. Patient knows that they're going to come for an ultrasound in a planned way, get an HSG done, get an answer, and then that's it.
Yes. Okay. Thank you so much, sir.
Okay, sir.
Sir, don't you think that after HSG, patients should not have sex at least for 1 week?
Yeah, ma'am.
We have done a procedure that we have sent all the things inside till the peritoneal cavity. The patient should not have sex for at least a week.
Madam, this is again, I'm saying this is the topic I'm not touching. I'm just want to discuss HSG. These are things which will never take us to any answer. But definitely yes. But how can you tell them not to be together? HSG is a procedure it's a procedure. You just tell them in case they're comfortable. Once you do an IVF or an embryo transfer, the commonest thing is that when can we have sex? The patient wants to ask us after ovum pickup, they want to ask us. Can we be together from, I say today I've got an ovum pickup done, what are you talking? So actually this is a topic I don't want to discuss because we won't reach anywhere in this. But yes, to be done in follicular phase with proper guidance and to be preceded by an ultrasound. It was lovely being with you. We had around 280 people who connected today.
Yes, sir.
Excuse me, sir. Sir, what is
Dr.
your view
Shagufta
regarding
is-
palposcopy?
Hi, Dr. Amit. Just wait a
Hi.
minute. I just want to connect with Dr. Shagufta, ma'am. She was trying to connect with me. Hello, ma'am.
Hi, Pooja. Can you hear me now?
Yes, ma'am. Yes, please. Hello, sir. Ma'am is here.
Can you put on your camera, Shagufta? We can't see you.
Sir, just a minute, sir. I'm switching on this camera.
Have you all got Resonance 5 in your mailbox? Could someone check and tell us?
Yes, sir, we've got it.
Thank you. She's your author. She is the person who has put
Very
so
good
much of
morning.
hard work. Hi, Shagufta. How are you?
Thank you, sir.
We lost you in the morning. Thank you
Sir,
so
I
much for
was
writing such a
stuck in
lovely bulletin.
emergency, sir. I was
No
in an
problem.
Yeah.
Lovely bulletin. Would you like to talk about your bulletin, Shagufta? She's one of our very brightest alumnus. Yeah.
First thing I want to thank you, sir. You all, can you hear me all?
Yes, ma'am. We can hear you.
So first thing I want to thank Pankaj sir so much. He has been so supportive and he has been so encouraging all the time. And I am an alumnus, but I will be the student of ICEG for rest of my life.
That's great.
Thank you, sir. Thank you for the opportunity. And yes, I did put in a lot of hard work, sir, for this. I think the first half of the Ramzan month I was spending on this.
Great.
After my OP and after OT, even every time I was spending the time with this, sir. Thank you so much for the opportunity. And I would love to be a student for the rest of my life. Thank you so much. The
Thank
best
you.
thing was you could get the expert advices, be staying at home. That was the best thing of your lectures, sir.
No. We are all learning from each other. Thank you so much for joining us and thanks for connecting. Thank you very much.
Thank you so much, sir.
I feel very sad that I was not a student at the age of 17 with you.
अरे मैडम हम आपके स्टूडेंट हैं. We are your students.
No, sir.
We are all. It's a
No,
gang.
sir. I think we will have to be born again for that.
मैम 4 किताबें पढ़ के को टीचर नहीं बन जाता.
नहीं sir, आपकी जो depth है ना, depth of understanding is too high.
And the way you teach, sir, the way you teach is very extremely good.
Yes,
We don't feel the kind of stress we are learning.
You can teach a dumb fellow, sir. Dumb fellow you can.
My God, I'm इतना dumb. मेरा IQ बहुत low है, तो मुझे उसी तरह से बात.
You can teach a dumb fellow.
Hello, great. Thank you, Shagufta. Say hi to your mom.
Thank you, sir.
Fantastic, Dr.
Greetings, sir.
Pankaj. One again,
Hi.
a very beautiful lecture from you on a very simple subject, but really very good.
Any comments from your side, ma'am? Any of the seniors who have done HSGs for ages, they can comment for one minute each, then we close down.
I have one comment that you have opened a third eye for me.
Thank you so much. Anyone with any comments? Anyone like to add something? Any of the seniors or anyone?
After listening to this lecture, I know that I was such a, what should I say, ignorant person pushing 10 ml.
Camera, please put in a camera. Let's see each other for some time. अच्छा लगेगा.
सर वो पता नहीं क्यों नहीं हो रहा है, इतना इग्नोरेंटली हम लोग कर रहे थे 10 ml पुश डाई करके एंड सीइंग द स्पिलेज, जिसके बारे में आपने फर्स्ट लाइंस में ही बता दिया कि HSG is not spillage, and always telling the patient, yeah, your tubes are patent. That is the only thing we were telling, because we were thinking ki polyp and rest of the things were seen by ultrasound. Really, sir, this has been a big eye-opener session, very big eye-opener session.
Wow, thank you so much. We had a query from Ramit.
Yes, Ramit, I'm really sorry. Please ask a query. And sir, we have around more than 60 queries in the chat box. So if we allow, I'll take a few.
Ramit, where are you? We can't see you.
Yes, sir. Thank you, sir. Thank you for the wonderful session. It was really informative. And sir, I had a question regarding salpingoscopy.
नहीं पता Ramit, मेरे को नहीं पता. I don't do salpingoscopy. I think anyone who knows about salpingoscopy can speak. I have no experience about salpingoscopy. ICSI, biopsies I can talk, but salpingoscopy is one thing I've never done in my life, so I can't comment. आप बताओ Ramit, you do so much of work. आप बताओ, anyone can share about
So
cervical.
basically, we use a 2.9 mm scope, and we try to introduce into the through the fimbrial end into the tubes, and we try to observe the fimbria. There's a particular classification whether they are normal, the projections are normal or they are flat. According to that, we classify, because we have to not see only the spillage while doing chromoprotubation. We have to see the function as well. So I've started doing recently only, but I just wanted to know from you whether what is your view regarding
I could never enter self-incoscopy 15 years back when we did. When 20 years back, we did a lot of these cases, 18, 20 years back. But around 15 years back, I left this part of the life. I've not done, मेरे को नहीं पता.
So the only advantage with the hysterolaparoscopy is that we can rectify the defect the same time.
Yes.
And that was the only thing, and we are not charging so much, so we try doing that only. But obviously first we go for HSG, after that we go for
life simple. We should keep life very simple. That's it. I mean, we can always go to lapro and do it, but is it required? Should we do anything invasive? That's my point.
Yes, sir.
It's just fine. Everyone has got his own way. I keep telling all my friends who join us now more than 480. There's something which is right for you, which you only know. Something which you really want to aspire and do self-incoscopies. You are very learned. And something which is very simple, which is good for the patients. So I'll draw a balance and give you a balanced statement.
Yes, but your lecture was really informative and really opened our eye regarding HSG. Otherwise, we were just looking for spillage. That's all, nothing else.
Self-incoscopy is the future, Amit. I feel it will be the future, but I don't know. I'll come and learn from you someday.
So it's like it's really like a big thing for me. How can you learn from me? How can you learn from me? It's the other way. You have made us learn so many things and cleared so many concepts. Okay, thank you, sir. Thank you so much.
लड्डू खिलाना हमें, वो किसके लड्डू खिलाती है पूजा? Okay. चलो, yes, Pooja. Quickly, we can take few questions.
So I got a question. Question is from Divya, Dr. Divya, and the question is: what is the importance of primary, secondary, and tertiary wave?
There is no importance per se, Divya, but we come to know how things are moving. It's something like when we are aging, you may say what is the significance of wrinkles on your face. You'll find so many young people here, and there's some people like me who need Botox and they need some anti-wrinkle treatment. So it's not that what is significant, that shares, that tells us how tubes are. That will tell us how the tubes are. A healthy tube will have multiple waves because it will respond. As the tubes start becoming not very good or they start aging, they lose their tone and response. This is one marker, and finally it will become flaccid. We talk about beading, flaccidity, lead pipe, rigidity. Normally tubes are moving everywhere. And as we are moving further, tubes will have less amount of those snake-like movements. It's becoming rigid, tighter, lead pipe, thicker. They'll go towards beading. So we keep in your mind that patient has got waterfall-like sign. Tubes are just going from the corner and falling down like this, or they are becoming lead pipe, thin. It gives you some idea about what may happen later. But there is no significance per se. But a good tube should have minimum secondary waves. Like a lead pipe tube will have a primary wave only, as you can know. Lead pipe means primary wave, straight tube. But as you move ahead, a good tube should have secondary or tertiary waves. This is what I like to just sum it up in short words.
So one question, please, sir.
Yes, Meenu, how are you?
Morning, sir. How are you, sir? I'm good, sir.
Great, Meenu.
So, sir, like when you said that when we put in the cannula, so you said that we should be able to visualize the alveolar orbiter in the cervix. So how much should we really screw in?
No, I'm just saying that we should not be trying to see it every time, but we should see. What I want to tell you is that what people do, not you and me do, मैंने भी बहुत गलतियां करी हैं. We screw the cannula inside so tightly that the whole of cervical what do you call it?
Architecture.
Rugosities, they get injured. See, after all, cervix, in case you put a scope through cervix, you'll find the cervix has got a lot of villi. So in case you just screw it so tightly, and your aim is to take it to internal os. See, what is our patients have primary fertility 99%. Right or wrong? You agree with me or not?
True.
So once you keep screwing this inside so tightly that it will go to an internal os, we are causing injury to the cervix. And our cervix
So
is,
sometimes there's a backflow also. Then what do you do about it?
that's okay.
Practically speaking.
When it happens backflow, then you do go in. But I'm saying that we should be trying to put cervix, give traction. I've seen many people, they just screw it and take out the valsalum. That's not the way. In case you have proper traction with the valsalum and just go in half a centimeter, less than that in the cervix, let the water flow. I'm saying just let the water flow. In case once in a while, 2 in 10 cases is a backflow, go deeper in, that's up to you. If you're just holding the valsalum, just screw it tighter, that's all you have to do. I want that when the fluid, don't injure the cervix, no? We are injuring cervix, and cervix leads to capacitation. And when you keep injuring the cervixes, there will be a problem with the embryo transfer later. Because it gets injured, it will form additions. So let the cervix be as it is. We should do a test without harming the patient, without harming a body.
Okay.
Have I conveyed to you my, you know how we have worked together. I'm very, very softy in these things. No harm should be done to the cervix and vagina.
Yes, sir.
Thank you, Meenu.
Thank you. Thank you.
So, may I take the next question?
Yes, madam.
Thank you. So next question is from Dr. Chaitra, and question is really simple. Sir, should we need to flush with normal saline post SHG? This is one question, sir, from Dr. Chaitra.
Flush what? What does she want to? Chaitra, what do we want to flush?
Post SHG.
No,
Dr. Chaitra, if you are with us, please come on the camera and ask your question.
What do you want to flush? The uterus you want to flush?
Dr. Chaitra, please unmute yourself, ma'am. You are muted.
Hello.
Yes, ma'am.
Yes, ma'am.
Hello.
Hi. Yes, you are audible, ma'am.
Sir, actually, good morning, sir.
Good morning.
Yeah, I do fluoroscopic guided HSG, sir.
Yeah.
So when we do fluoroscopic guided, one question is, can we induce in the same cycle?
Induce in the same cycle for what?
Hello.
Hello. Induce for what?
Like induction for ovulation induction.
No. The reason being,
or should we stop that cycle?
No, that cycle is only for workup. There's one workup month for the patient.
Okay.
Don't see, we put a dye inside. Dyes are water soluble. Agreed. But once you put it inside, there are a lot of lacerations are occurring in the endometrium. If not lacerations, injuries are occurring in the endometrium. So endometrium may be like getting teared at many places, and it may be bleeding inside. We don't know what's happening inside, because see, we can't be sure of how much pressure we are putting, what injuries we are causing. I feel that we should let that cycle go. At least I don't do it, man. And fluoroscopy or non-fluoroscopy, the method is the same. The only thing is that in fluoroscopy, you can make the uterus straight, up and down. Sometimes uterus is mal-positioned, and we are depending upon the cameraman to click a picture. But here, we are seeing it in front of us. So we can move the uterus up and down, rotate it, left, right, up, down, get the tubes in the right place. In case I see a beading somewhere, I go near the beading, put the uterus further and go near the beaded picture. That's the only difference, but otherwise the dye remains the same, amount of dye remains the same, and the injury will remain the same. This is I may be wrong, but this is what I'll have to comment on your.
Okay.
Better take rest, that's it.
Okay, sir. So
Second
there's
thing
a
is
question,
after
I think
the dye.
Yeah, please, Soumya ma'am, carry on. Charita ma'am.
Yeah. Sir, after putting the dye, should we flush with normal saline, sir?
I have never flushed in my life. I know if somebody is doing it, I don't know. We have never done it. I still don't do it. Probably I'm missed on some news. Somebody is doing it. I don't know. I don't do it.
But okay, sir.
I don't do it, ma'am. I don't know. Can someone comment upon that? I really don't know. I like to learn in case it is to be
Because
done.
one of the center, they actually told me to flush out with normal saline.
For
So
what?
after that,
It's a water soluble dye. It's a water soluble, not oil soluble. It's water soluble dye. It will go off in within seconds. The uterus is gonna. I don't know. In case anyone like to comment.
No, sir. I don't think it's a routine practice at all. It's not a routine practice anywhere.
Yeah, it's not a routine practice. I agree. Even I don't do it, Chaitra. I'm sorry, I don't do it. Okay.
Okay. So next question is it
Should we give
possible?
antibiotics? Antibiotics not to be given. Normally we don't give antibiotics. Pooja, sorry, I just saw a query popped in. I apologize
Yeah,
for that.
got it, sir.
Not to be given. In case you find patient has got some pain or something, or you doubt your sterility, yes, you may give some doxycycline or some painkiller. Painkiller I always give, but antibiotics not as a routine, but you can give. That is the non-debatable question. Personal choice.
Any comment on use of lipid oil? Lipid oil, latest.
Ma'am, no, I don't know what this chemical is.
They say that it improves the fertility also.
Ma'am, I don't know, ma'am. I am not aware of that.
In one of the essay they told us.
Ma'am, essay छोड़ दीजिए. ये सब essay का एक paper आ जाता है वो तो I shouldn't discuss. But actually, I don't know, ma'am. Geeta, ma'am, you want to comment upon this? You tell us. I don't know. I'm not aware, but learn from what you're saying.
But I'm also not using it. I'm using the water soluble.
In our country, you can't even get HSG dye. You try getting HSG dye, is not available. Only one vendor in the country is there to give HSG. So I think we should try to just keep it very simple. I don't know. I'm sorry.
Yeah.
Sir, excuse me. This laparoscopy dye test is more confirmatory or HSG?
Laparoscopy dye test is very stupid thing to do actually. That only shows the spill. But HSG will tell you how the tuberosal, what Ramit was talking about, salpingoscopy. HSG can become like a salpingoscopy procedure. So I say that last thing to do is the dye is looking at that spill.
Yeah.
Spill को तो सब दिख रहा है. Spill you can see. I can see you are 1 + 9 5G. I can see that, no. And on your left side is Dr. Fawzia. So what is fun in this? That is seen already. So I'm saying HSG is a much better option.
Sir, one last question, please, sir.
Yes.
Sir, if we are missing the 3D USG and directly going for the HSG, which normally 99% of the practicing gynecologists are doing, so what are the things we are missing actually?
3D we should only do in case you have a suspicion on a 2D. See,
Okay. Sir, suppose we are not doing a 2D and straight going for a HSG.
You should do a 2D. You should do a 2D, ma'am. Without doing a 2D, your outcome will suffer. See, when I do an HSG, I already know what lies inside. If there is a hydrosalpinx, why should I do an HSG? In case there is a gross endometriosis, why should I do HSG? There is a contraindications हो जाते हैं HSG के वो. So I always like to do a 9th or 10th day, 11th day, 12th day scan in the morning and then carry out HSG. So the whole thing gets over the same day. In case I find there is a polyp lying somewhere, I just confirm the polyp by 3D within 10 minutes, and then we put the dye. So things have to be, back-to-back things should be done in one day. 1 day, 2 hours, you get an answer. Otherwise, that's the way I work now because I like to work up the patient within 2 to 3 weeks of their coming to me. Now they should linger for days and months with complications without knowing what they're getting into.
So what I got is that you do when everything is right for ovulation. You are doing everything in that stage so that you can see that perfect total stage.
Exactly.
Starting from the cervical mucus onwards.
You see the follicular size, you see the endometrial growth. When you find that there is Asherman, the endometrium is not forming, follicle is 20 millimeter, you know that there is a problem with the endometrium. Now you do an HSG, you get the same thing there. So we should combine. The cavity is looking small. You do a 3D before, you find cavities 1.5 ml. You do an HSG, you get better outcome. Karna to hai. See, we do all these things, but we do in a scattered way. So once you do everything yourself, you get an answer right away. In 2 hours, done and dusted.
So
should we follow for this HS?
No books. Hi. No books to be followed. I'm giving you all the articles. You don't need to read anywhere. Once you come to IC, you don't read. That's our responsibility.
That is for sure, sir. The experience. I also want to thank Pooja. Exclusive to very good days hands-on we had. It was too good.
I know. Pooja has my sheet hai.
Yeah, you have been extremely kind and good to us in the last 2 days. We learned a lot, all silly questions answered with lots of patience and very good hospitality also. Very, very good hospitality. We were at home for 2 days, absolutely.
Great.
Thank you. It's a kind of honor and actually.
Chocolate for Pooja. Chocolate box for
Extremely
Pooja.
kind and extremely good. Extremely, we felt at home.
Excuse me, sir. Can we get recordings on the group for this session?
No, we don't give recordings, sir.
So I have, sorry to interrupt you. I've got a question. May I ask?
Last question. Pooja, last question. I have to go to the OPD. 10:30, please stop.
Fine. So question is if the patient is on hormonal contraception, does it affect HSG results?
Yeah, I should never put patient on hormonal contraception because that will make the endometrium tightly packed. We are looking at the endometrial thickness, endometrial growth on HSG also, no? We're not looking at spill. I told you spill is the last thing on my mind. Spill I don't look at, in fact. Spill is seen. Your name is Pooja Avasi. It's written there, na? So I'm not doing HSG to read your name. I'm doing HSG to look inside your mind. So in case you give OC pills, the whole of the follicle won't form, the mucus won't form, the endometrium won't form. It won't be a good thing to do.
Okay.
In natural cycle, everything natural cycle.
Okay. Sir, Dr. Panchdev, sir, is actually raising hand. He wanted to, I think, connect with you. Dr. Panchdev, please ask the question.
I have to go to OPD. Last question now.
Okay.
Yes.
Sir, hi, sir. Excellent lecture. Fantastic, sir. Fantastic lecture and very much a clinical perspective what you have taught in very few seconds. Actually, you have erased a hysteroscopy and a laparoscopy completely, which cannot be diagnosed in spite of doing the hysteroscopy and laparoscopy. And this is very much important in a rural practice.
Correct.
Because in rural practice, patient doesn't afford to have this operative procedure, and it is very so much important outlining, because I have seen lot of gynecologists, they are not doing this. They straightforwardly going for hysterolaparoscopy for monetary gain. This one message cutout you have given very much clear that you can rule out with this. And plus I am very much appreciating you adding the sonography before doing it, because this thing what just previous slide doctor told 99.9%, I will recommend it is 100%. Patient doctors, gynecologists, they do directly HSG without sonography,
knowing what they are in for. Correct.
This is very much you have actually eye opening. ये जो curtain raiser नहीं, I think you should make a sentence change. It's eye opening. It's not curtain raising.
It awakens your third eye.
You actually should rename this. It's eye opening. It's not a curtain raiser. It's eye opening.
Thank
One
you,
question
sir.
I should I just have one query, sir.
Yes, sir.
Can we, because now you have cleared that we cannot have a pain that much, pain injury is that, but can we add SSG, sonosalpingography?
Yeah. See, many people add. I'm not very fond of that. See, why do people do sonosalpingography? They want to look at the spill. No, spill is the last thing in my mind. See, I differ. Spill का क्या करेगा मैं? Spill तो दिख रहा है. Spill is तो दिखेगा. Spill is left or right, you can't make out. Spill is, what will spill show me? Spill is not on back of my mind much.
So you mean ultrasound will not show the same thing as the fluoroscopy?
Yeah, no ma'am, I'm saying SSG is basically putting some saline inside.
Yes.
We do SSG routinely, but to look at a polyp, not for the spill. When the patient comes to me, I think it's a polyp or a myoma inside or a Sherman. What do I do? Immediately do SSG. In 2 minutes, I'll confirm, but you can SSG. So that's confirming a particular finding. But I would like to do replace HSG by SSG. Replacing
perform TBS in the morning of HSG.
इशरत तुम्हारा कैमरा ऑफ है तुम्हारा इशरत तुम्हारा कैमरा क्यों ऑफ कर तुमको देखा नहीं था अस्सलाम वालेकुम इशरत how are you not seen you from so many days we're missing you
Sir, sir, I am also with you and I tried, but the Sunday, you know, sir, we have office from 6 hours. That's why I can't
your
join
Sundays
you.
are Monday. She's from Bangladesh.
Yes,
Our Monday is
yes,
their
sir.
Sunday.
Yes,
Correct,
sir.
I know.
I never dare to request you to arrange such a nice class on Friday.
Can't.
Sir,
Inshallah,
that's why
someday.
I can't join, sir. But I have a strong desire to join, but I can't, sir, because my office starts from this.
I know.
Sir, I wanted to ask you a question that should we do routinely TBS on the day of HSG?
Yeah, I told you it should be done, always be done. Before you do HSG, we should know what the findings are. I mean, that's the ideal right way to do. In case you want to do one ultrasound, it should be done before on day 9 or day 10. You should have the finding in your hand all the time before you send the patient.
That's the TBS, not the transabdominal.
Transabdominal probe should be thrown from any IVF lab. There is no role of a transabdominal probe in any IVF lab. We only use TVS. Transabdominal only we use when rarely, I mean, I use transabdominal once in 3-4 months. There is no role of TAS for infertility management. It's only TVS. When you can't make out something, unmarried girl, a lot of unmarried girls now come to us. For them, TS is okay. But TS is normally kept in a box. We don't keep it in the machine also. It's got indication, but take it out when required. But don't keep TS probe in the IVF. But keep it with you.
Thank you, sir.
Okay, Ji. Hi, Dr. Chan. How are you? Not seen you from so many. Hi. Good seeing you. I can't see all of the friends. I'll just scroll through, then I'll say goodbye because long day ahead for me. So many of you have joined. Yes.
One second.
Yes,
Good
ma'am.
morning.
Yes, ma'am. Yes, ma'am.
Sir, while doing HSG without giving any sedation or anesthesia, patient complain of pain when we hold the lip of the cervix with valsallam.
Yes, madam. You can give them, in case you feel patient has got some pain, you can give her a diclofenac pessary before that, 1 hour before the procedure, or you can give her anesthesia. It's worthwhile giving her some ketamine, doing her case, then to do her or compose, then to do and get a coronal spasm and block tubes. Because you find she's gonna be uncomfortable, then give her some anesthesia, give her some painkiller. It's worthwhile. But
can we apply
don't you think that we can give some antispasmodic before that, like Buscopan?
You can. I'm saying you can. There's nothing wrong in it. But yes, don't get a coronal spasm. Otherwise, the procedure is wasted. They lose around ₹7,000-8,000 rupees and they'll waste their money. And then you advise laparoscopy because we have not done it properly. See, she's not a vegetable. Any patient coming to us, she's not a vegetable. They just come and just cut her, take her, lie down, put a cannula. That's not the way. She should be treated with a lot of respect. And you must gauge her pain index before you're doing it. And see, it's give and take. You give her respect. You give any woman a respect, her corno is gonna give respect to you. Corno has to reciprocate. Corno gets angry with you. Whatever you keep pushing inside, you'll have intravassations, extravassations, you'll have blockages. What is the purpose? And corno, you have to relax her by talking to her. The coronal spasm should not occur. I think I'll say goodbye here. I am so sorry, but I got some patient lined up at 10:30 in the morning. I still have 100 people and lovely guys, all guys and girls. Thank you so much. Thank you so much. We have so many people from abroad today and thank you so much. Thank you so much. Dr. Jyoti is here. I like to say hello to her. Shagufta, thank you so much.
Sorry, sir, to interrupt. Happy Friendship Day to all on this special day. You have given us a very good lecture. Thank you. Thanks a lot, sir.
Wow. So I was also about to say, wish all of my friends in India and
Thank you,
abroad
sir.
before actually closing this session. Very happy Friendship Day. And my oldest friend, Dr. Pankaj Talwar. Sir, happy Friendship Day.
Thank
And
you, thank
my
you, thank
lovely
you.
audience. Thank you so much for being a part of ICIT family. And you are our strength. Be connected. Stay with us. And definitely we will share and we will exchange a lot of knowledge. Thank you so much.
Thank you.
And
Bye,
have a-
everyone.
Thank
Bye.
you.
Bye.
Thank you all.
Take care. Bye. Bye. Bye.
Bye
Thank,
bye.
thank you, Pooja.
Bye
Thank you so
bye.
much. Bye.
Bye.
Bye. Bye.
Bye,
Bye,
sir.
everyone.
Everyone.
Bye. 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 Take care. Bye.